Well, greetings, everyone, and welcome to the EKG Case of the Week for June 2nd, 2014. Happy June, everyone. Well, this week we've got a bread and butter case. Last week we had a relatively longer video cast as we went through the answers to our residency's annual EKG competition. If you didn't check that out, go back and take a look at last week's case and try to go through that test and figure out the answers for yourself. It was definitely challenging. This week's case is going to be definitely more bread and butter. Before we get there, however, I wanted to just let everybody know about an upcoming advanced EKG workshop that Dr. Bill Brady and I will be doing. Bill is a good friend and a fellow EKG nerd who works down at the University of Virginia in Charlottesville. He's a full professor of multiple things, including emergency medicine, and a super fantastic teacher and a really nice guy. Anyway, he and I are going to be teaming up to do a pre-conference workshop at the next International Conference on Emergency Medicine conference, which is going to be in Hong Kong. There's the website, www.icem2014.org. And the date of our workshop is going to be June 10th, 2014. So if you're going to ICEM and you haven't signed up for a pre-conference workshop, this is going to be a really good one. And also, I should probably just let you know, I do not have any financial disclosures to disclose in telling you about the workshop, is because I think it's going to be good, and I really hope to meet a lot of people there. So one of the fun things about conferences is an opportunity to make a lot of new friends. And many of you have emailed me great cases. I hope to finally put a face to the names of many of you who have been emailing me. So if you're going to be in Hong Kong next week, starting next weekend, I guess. Well, actually, it's probably starting, this is June 10th on Tuesday, but the pre-conference stuff starts on Monday. Our conference is June 10th, and then the main conference starts on June 11th. Hope to see many of you there. Okay, on to this week's case. Again, bread and butter, and hopefully some of you will know this right off the bat, but there's some interesting teaching points about this particular rhythm that we'll talk about. This is a 65-year-old man that I took care of a few years ago, who presented to the emergency department with altered mental status, and he had a systolic blood pressure of 75. Now, this is a slightly older patient. He's got altered mental status, so you're going to go ahead and you're going to do the full workup. You're going to shotgun lab, CBC, Chem 50, maybe a Chem 100, LFTs, ammonia level. You want to make sure to get the BUN, creatinine. You're going to get a chest x-ray and a CAT scan and an MRI and a PET scan and multiple consults. Well, maybe not. Hopefully, you're going to be more cost-effective than that, but you are going to look broadly for causes of altered mental status in an older guy. And also, he's got hypotension, so you're going to be initially treating shock. And one of the first things you're going to do with somebody who's hypotensive, and one of the first things you're going to do with somebody with an altered mental status, of course, is to get an early 12-lead EKG. And this was the 12-lead EKG that we got. And I think we've talked some about differentials of tachycardias, and so we're going to briefly do that again here. But just looking at the rhythm strip here, you notice that this patient has an irregular narrow complex tachycardia. And recall that when you have an irregular narrow complex tachycardia, there's only a few possibilities, but the guy's hypotensive, and so you may want to do something about that even before you get to the diagnosis. Now, I've taken ACLS a number of years ago, and I try not to take it anymore. Many of you have taken ACLS, and any good ACLS provider knows that when you have a hypotensive, unstable patient with a narrow complex tachycardia, almost regardless of the rhythm, what are you going to do? You're going to light them up. You're going to shock that patient, right? Well, hold on there, cowboy. Maybe it's not such a great idea to shock the patient the way Julia Roberts is doing in this god-awful movie from 1990 called Flatliners. Maybe not such a great idea. All right, so let's talk about the rhythm before we jump into shocking people, as they did in this movie. If you haven't seen the movie before, I would not waste your time. Anyway, this is the differential that we need to remember for narrow, irregular tachycardias. There's three main things you need to remember. Practically Only 3. If you remember these 3 causes of narrow irregular tachycardias, you're going to nail the diagnosis in probably more than 90 or 95% of the narrow irregular tachycardias that you see. Atrial fibrillation, atrial flutter with variable conduction, right? And multifocal atrial tachycardia. How do you tell the difference between these 3? Well, you simply need to look at what the atrium is doing. What is the atrium doing? With AFib, of course, there's no distinct regular atrial activity, and so oftentimes it just looks like a wavy baseline. Early atrial fibrillation can sometimes be very lumpy, bumpy, and that's called coarse AFib. Sometimes people mistakenly call that atrial flutter, but if you map these blips or bumps out, they really don't map out regularly, and also they're going way too fast. Just remember, AFib is lumpy, bumpy, no clear-cut P waves that map out. All right. Atrial flutter has very rapid atrial activity, and the atrial beats do map out. I'm not going to try again to draw it. You've seen flutter many, many times before. It may give you a sawtooth appearance. Sometimes it's a little bit subtle, and you want to always make sure to look in V1 and V2 because sometimes those are the leads that show flutter when no other leads show you flutter. We've talked about that before. We're not going to go back into it this time. Usually atrial flutter is regular and fast because usually atrial flutter gives you an atrial rate of 300 with 2-to-1 conduction. So the atrium's beating at 300 and the ventricle's beating at a nice regular rate of 150. However, instead of having 2-to-1 conduction, if you have variable conduction, in other words, in some places it's 2-to-1, in some places it's 3-to-1, in some places it's 4-to-1, well, the resulting ventricular rhythm can be irregular. So don't forget that atrial flutter can be irregular oftentimes. And then the third possibility is multifocal atrial tachycardia. Well, what's the atrium doing there? It is, quite simply, multifocalizing. And that is a word. Go look it up. All right, so essentially you do see P waves, but the morphologies of the P waves are changing. And by definition, there should be at least 3 different morphologies for P waves. So you pretty much will see P waves with every QRS complex, but they're changing in morphology. There should be at least 3 different morphologies for the P wave. So let's go back and take a look at this rhythm once again. It's irregularly irregular, so there's 3 possibilities: AFib, A flutter with variable conduction, and MAT. If it's AFib, we're going to shock them because of this hypotension. If it's A flutter with variable conduction, we're going to shock them because of this hypotension. If it's MAT, maybe not. All right, and that's why it's important to actually come up with a diagnosis before you just jump in and shock a patient with these narrow complex tachycardias. So how do you tell the difference between the 3? You need to look at what the atrium's doing. So let's look down there at that rhythm strip, and what you notice in that rhythm strip, there's a P wave right there, and there's a different looking P wave, and there's an inverted P wave. So right off the bat, we've got 3 different morphologies for P waves. Maybe there's a 4th one there that's a little bit taller and a little bit more sharp looking. That's inverted again, and that's kind of normal looking up there. There's a little bit of a biphasic one. There's kind of that's a funky looking one. And there is an inverted one, and there's a really sharp inverted one there. So there's at least 4, maybe more different morphologies for P waves. And the other thing that you'll notice is that the overall resulting rhythm is irregular. The PR intervals are changing a little bit. I don't see any that are really long, but they're not all identical PR intervals. And so this, for all the world, is looking like multifocal atrial tachycardia, and that's exactly what this is. This is multifocal atrial tachycardia, or MAT. So, again, this is a bread and butter rhythm. It's not that common. They say that you probably see it in about 0.2 to 0.5% of all EKGs, which, if you get a lot of EKGs, you're going to see it. I'm surprised it's even that common, because I probably see MAT, I don't know, maybe a couple of times per year. It's not that common, but it is something that you are going to see, and definitely it's something that you need to know for the board exam. All right, so be on the lookout. And also, if you see a lot of pulmonary patients in your practice, you're going to see MAT, because those are the major patients that manifest MAT. It's most often associated with pulmonary disease, either acute or chronic, and typically the patients are having an acute hypoxia problem. They may be having traditionally a COPD exacerbation. Patients may have this. In recent years, I've seen patients with bad asthma attacks present with this. I've seen this with pneumonia, and this patient we'll come back to in a second, but this patient turned out to have pneumonia and COPD. And I've also seen this occurring a little bit more often in pulmonary hypertension. And I don't know about your practice, but in our practice, it sure as heck seems that in the past 5 years, we're seeing more pulmonary hypertension patients than certainly back when I was in residency 20 years ago. All right. Now, looking at the literature on MAT, there's a few additional things that might be worth knowing as well. There's a few contributing factors. Beta blockers and the use of theophylline tend to be contributing factors to MAT. Now, theophylline, I don't know if I've heard that theophylline toxicity can cause MAT, and it's no doubt that pulmonary patients, especially COPD patients, are more likely to take theophylline. Beta blockers do not typically get started on patients with pulmonary disease except CHF patients. And so it may be that CHF patients that are on beta blockers may be at slightly increased risk for MAT. Again, this is not a huge risk factor, but it's listed in the literature as a contributing factor. My guess is that it's a very slight contributing factor. Also in the literature, hypomagnesemia and hypokalemia tend to be predisposing factors for this as well. Hypokalemia, not a surprise, because a lot of these are pulmonary patients who use their nebulizers a lot, and nebulizers cause hypokalemia. And older patients tend to be hypomagnesemic as well. The literature also seems to indicate that MAT is often preceded by a lot of PACs. All right, MAT in some ways is just a patient with PACs gone wild. Premature atrial complexes gone crazy, all right? So oftentimes these patients will show a lot of premature atrial complexes before they go into full-blown MAT with the 3 morphologies and the tachycardia. And the literature also seems to indicate that patients with MAT are at a slight predisposition to go on to develop atrial fibrillation or atrial flutter, maybe not during their emergency department stay, but maybe during their hospital course or a little bit further down the road. So there's an association with AFib and aflutter. Now, MAT in and of itself is not a destabilizing rhythm. Almost never does MAT cause hypotension. You know, if somebody's in VTAC, well, VTAC can cause hypotension. If somebody's in rapid AFib, going at 160, 170, that can cause hypotension. If somebody's got an unstable Brady dysrhythmia, that can cause hypotension. But MAT very rarely ever causes hypotension. So if you see a patient that's hypotensive in MAT, chances are it's not the multifocal atrial tachycardia that's causing the hypotension. So there's not an emergent need to lower the rate in order to get their blood pressure back up. If somebody's hypotensive with MAT, think about other causes for the hypotension. Treat them for sepsis, treat them for hypovolemia, and so on. All right. There is some literature also that seems to suggest that if a patient with a pulmonary infection or respiratory failure or acute CHF develops MAT, that the development of MAT predicts a worse prognosis, not itself because of the MAT, but MAT is simply a marker of a worse underlying pulmonary disease. All right, so hopefully that makes sense. So don't go crazy in rushing to treat the rhythm. Focus on the underlying cause. And if somebody has MAT, that's essentially what that simply means is that that's a sicker pulmonary patient. And what are you going to do differently? Well, I don't know. Maybe you're going to just be a bit more aggressive and be a bit more worried about that patient. All right. In terms of the EKG findings for MAT, there can be no dominant atrial focus. All right. Essentially, you see just a lot of different types of P waves. So this is not a scenario where 90% of the P waves are one morphology, and then there's just an occasional different beat here and there. All right. Because that would imply that there's a dominant focus. In this particular case with MAT, there is no dominant single P-wave morphology. It's just kind of a random scattering, fairly even scattering of the different morphologies. Again, I hope that makes sense. And there has to be, as I mentioned, at least 3 morphologically distinct types of P waves. If you do see a dominant atrial focus, all right, dominant atrial focus, then that's simply sinus rhythm with multiple PACs. But MAT really is defined as multiple P wave morphologies, but there's no one morphology that truly dominates the rhythm. Right? With all these different P waves, you're going to have variable PP and variable RR intervals. In other words, it's irregularly irregular. Let me get rid of all this chicken scratch. It's irregularly irregular. The P to P intervals, the R to R intervals can vary. But the other thing to keep in mind is that the PR intervals can vary also, as we saw in this case. You might have a prolonged PR. You might have a more normal-looking PR. So the PR intervals are not all identical. In fact, some P waves may not even be conducted. There may be non-conducted P waves in there. Sometimes if the rate is relatively fast, you may have some P waves that get conducted aberrantly. So maybe you're going to see some P waves that get conducted with QRS complexes that look like a right bundle or a left bundle, or just some non-specific widening of the QRS complex. That is not at all uncommon. Okay, and finally, the rate. The rate is usually not that bad, 100 to 150, as it was in this case. I think the rate in this patient was about 130 to 140. But the literature suggests that you can have rates that are really fast, up to 250. I'm sure that's pretty rare. And you can have rates that drop below 100 just a little bit to 90 or so. And for completeness sake, when I was in residency being taught by the famous Dr. Edward Chung, I learned that if the rate's under 100, it's not tachycardic, and that's actually called wandering atrial pacemaker. Some of you may have heard that term before. Wandering atrial pacemaker and MAT are the same thing. It's just that if the rate's under 100, it's called wandering atrial pacemaker. If the rate's over 100, it's called multifocal atrial tachycardia. All right. So the rate can be variable, but usually you're going to see rates in the low 100s. How do you treat these patients? Well, if you alluded to this already, you want to treat the underlying respiratory problem, and almost always it's a respiratory problem. Even with treatment, apparently MAT can sometimes persist for days, and in this patient that we presented, the MAT went away probably by the next morning. It did slow down, but it went away not until the next morning or so. This is a rhythm that you do not treat, all right? So ACLS would have you believe that everybody who's unstable with the tachycardia, you're supposed to shock them, but not so. There's 2 tachycardias that you never shock. One of them is sinus tachycardia, right? I mean, you would never shock sinus tachycardia. That's just dumb. And MAT is the other tachycardia that you don't want to shock, because all you're going to do is really piss off the patient. All right, you're going to make them really angry. Excuse my language. You're just going to make the patient really angry. Your patient satisfaction scores are going to plummet. Hospital administration is going to come and yell at you, because invariably it's going to turn out the patient you just shocked is a member of the board of directors. All right, so do not shock these patients. If they're hypotensive, give them fluids. If they're infected, give them broad-spectrum antibiotics, treat their sepsis, and so on. But the hypotension is not due to the MAT. So treat the underlying problem, and that's about it. You want to make sure to correct the lights. Some people have talked about just giving empiric magnesium, and I did see that in a couple of the EKG books. That's not based on great literature. It's probably just some gestalt that a lot of these patients are hypomag, and giving a little magnesium is usually pretty harmless, so why not give them some empiric magnesium? And some people have said that if you really, really want to lower the rate, you can use verapamil. You wouldn't want to use beta blockers because these are pulmonary patients. But if you really want to get the rate lower, just because you simply don't like the rate, then you can use verapamil. I have not done that before, and most people I know, the cardiologists and the pulmonary docs, do not use verapamil. But I suppose if you had that very rare scenario of a heart rate of 180 or 190 or something really, really fast that's making the patient extremely uncomfortable just from the palpitations, then I suppose you might want to try to lower the heart rate just for comfort's sake with some verapamil, presuming the patient's not already hypotensive. But again, if they're hypotensive, it's not due to the rhythm, right? Again, you do not want to shock these patients. Don't shock them. Just treat the underlying cause, give them some fluids, give them empiric magnesium, why not? And usually you won't even need to give verapamil, but some people do talk about it, and so I just want to mention that. Okay, here's another example of multifocal atrial tachycardia. We've got 3 rhythm strips up here. Once again, it's irregularly irregular, and you take a look at the P-wave morphologies, and there's a P-wave morphology. There's another one. There's maybe another one. There's an inverted one right there. So there's at least 4 different morphologies here. Maybe a large P-wave, maybe a 5th morphology up there. And there's no one dominant P-wave morphology, so there's kind of a random scattering of different types of the 3 or 4 different types of P-waves. This is multifocal atrial tachycardia. And going back to the patient we started with, we've already looked at the P-waves. This patient ended up having pneumonia and also got treated for a COPD exacerbation, and that was the cause of this patient's mental status change. And once the patient was treated for the pneumonia and COPD, the patient ended up perking up and doing okay. All right, so quick take-home points. Remember, multifocal atrial tachycardia, it's irregularly irregular. The 3 things that give you irregular rhythms are AFib, aflutter with variable conduction, and MAT. How do you tell the difference between the 3? You look at what the atrium's doing. With MAT, you're going to see P waves, but at least 3 distinct P wave morphologies without a single dominant morphology. Treat the underlying cause. Almost always it is related to pulmonary problems and hypoxia. And again, don't shock these patients. It doesn't help. It just causes pain. All right. And the last thing we want to do is to unnecessarily induce pain in our patients. All right. So I hope that was helpful. MAT, bread and butter, good for the boards, and you will see it. Don't shock these patients. Treat their lungs. I hope that was helpful. And I look forward to talking to everybody next week. I hope next week, actually, I see some of you in Hong Kong at that convention center. All right. Until then, take care.